All right, let's jump right into this. We're going to do a clinical deep dive on Trypanosoma cruzi, which is the parasite behind Chagas disease. It's a fascinating and often overlooked condition, so let's break it all down.
So here's our game plan. We'll start with the organism itself, then we'll walk through how it gets around, what the disease actually looks like in a patient, how we figure out if someone has it, and finally, what we can do to treat and prevent it. Ready? Let's get to it. Okay, first things first. To really get a handle on Chagas disease, we have to meet the family, so to speak, the Trypanosoma genus. This table is awesome for a quick side-by-side comparison. Up top, that's our focus, T. cruzi. Notice that the vector is the reduvid bug, and here's a key point. Transmission is through its feces, not its bite. And for us clinicians, the most important part is that the disease itself is caused by the M. mastigotes, hiding out in cardiac muscle and neurons. Now contrast that with the African trypanosomes down below. They're carried by the tsetse fly, transmitted through saliva, and it's the trypamastigotes in the blood and brain that cause the damage. These differences are absolutely fundamental. Okay, so now let's zoom in specifically on T. cruzi's transmission cycle. This is where the story gets really interesting. So this is the main culprit, the reduvid bug. You've probably heard its nickname, the kissing bug. And no, it's not a term of affection. It gets that name from its lovely habit of biting people on the face, usually around the mouth or the eyes, typically while they're fast asleep. Now, this diagram might look a little complicated, but it's a perfect roadmap of the parasite's journey. You can see the parts of the cycle that happen inside the insect, and then what happens once it gets inside a human host. We're about to walk through exactly how this happens. Okay, now this is the detail that trips a lot of people up, so listen close. You don't get infected from the bite itself. What happens is, the bug bites, has its meal, and then it defecates right near the wound. The bite is itchy, right? So the person scratches it, and in doing so, they literally rub the parasite-filled feces right into the bite wound, or maybe their eye. Once inside, the parasites invade our cells, they transform into mastigotes, and they just start multiplying like crazy. This is the moment the disease truly takes hold. And understanding that life cycle is absolutely essential to understanding how the disease plays out over time, because let me tell you, this disease is notoriously deceptive. This timeline really shows you the insidious nature of Chagas. That initial acute phase, for the first couple of months, it might just look like a non-specific fever, maybe some swollen glands. It's so easy to miss. But the real trap is what comes next, this massive gap, years, sometimes decades, where the person feels perfectly fine. This is the asymptomatic phase. But while they feel fine, the parasite is still there, silently causing damage that won't show up until much, much later. And when that chronic phase finally hits, the damage is severe. The main targets are the heart and the GI tract. In the heart, those mastigotes cause a chronic inflammation that just chews up the muscle, leading to life-threatening arrhythmias and eventually heart failure. And it's not just the heart. It also damages the nerves in the gut, causing the colon and esophagus to lose their muscle tone and balloon out, which we call megacolon and megaesophagus. So you can see the problem here. You have a disease with a mild, easily missed acute phase that then goes silent for decades. So how on earth do you diagnose it? How do you find the parasite?
So let's think like a clinician. You've got a patient, they're from an endemic area, they have a fever, some facial swelling. What's your first move in the lab? What test do you order?
The key is to look for the parasite where it's hanging out during the acute phase, and that's the blood. So the gold standard, your go-to first-line test, is a simple blood smear. You're looking for those little motile trypamastigotes swimming around. But what if the number of parasites in the blood is low and you can't find them? Well, that's when we have to go down this diagnostic funnel. You can go for tissue biopsy, trying to find the mastigotes hiding in the muscle. You can try to culture the organism. And then there's this really fascinating classic method called xenodiagnosis. You literally let clean, uninfected lab bugs bite the patient, and then you dissect the bugs later to see if they picked up the parasite. You're essentially using the vector as a living diagnostic tool. So once we have a diagnosis, what can we actually do about it? And probably more important, how do we stop people from getting it in the first place? For treatment, we really only have two drugs, nifurtimox and benzonidazole. Now here's the crucial thing to understand about them. They're pretty good at killing the trypamastigotes that are actively swimming around in the blood during the acute phase. But their big weakness? They are way less effective against the mastigotes that have already burrowed into tissue cells. This is exactly why early diagnosis and early treatment are so critical for a good outcome.
And this brings us to what is arguably the most important point of all. We have no vaccine. There's no prophylactic drug you can take to prevent Chagas. This means prevention is everything. It all comes down to public health measures, vector control through better housing and insecticides, using bed nets, and, this is huge, screening blood and organ donations to stop transmission through those routes.
And that really leaves us with this final, critical question, especially for those of you in medicine. When you have a disease that's silent for decades, how do you even think to look for it? It really just underscores how vital it is to take a good travel history and to keep Chagas on your differential diagnosis for anyone with unexplained heart or GI issues, especially if they've ever lived in an endemic area. It's a huge challenge of just pure clinical suspicion.